My name is Andrew Pinto. I'm a family physician and public health specialist who works at the St. Mike's Hospital Family Health Team. I do clinical work about 25% of the time, and most of my time is as a scientist doing research. I direct a research team called the Upstream Lab. Our team is made up of about 30 staff and about a dozen graduate students now. And we focus on three main areas: tackling the social determinants that influence our health, and I'll talk a bit more about that, population health management, and how can we help health authorities and large hospitals better manage populations that they serve. And the third area is using data science to enable a learning health system. I also have a role in supporting clinical trials that engage primary and community care. For example, we just have recently launched a really large study called Can Treat COVID, which is testing COVID therapeutics. So I've been asked to give a short presentation just to orient you to a few different areas and then to provide some thoughts about primary healthcare and where we're going, in particular related to issues around equity. So one of the first things is just to explain a bit about what the social determinants of health are. I think this is a term that's becoming more familiar, but just to lay it out, these are the factors that influence all of our health that are really related to the environment that we live in and also social characteristics that we have. It's really the fact that our health is largely determined by our context, and actually only to a small extent determined by things like health services that we receive. And how we know this is if we look at the differences between different groups in terms of their health outcomes. A lot of it ends up being related to people's income, people's job status, people's housing, and also things like connectedness to others, how socially isolated they are. And only a small amount of the difference between people seems to be explained by their use of health services. It's still important, and of course, who has access to health services is related to these other factors, things like income, education level, and other factors, including things like our race and how we're perceived by others, things like our disability status. So the social determinants of health are these really important factors that relate to who we are and also relate to the society that we live in, that end up determining our health, and also influence our access to health services. So those differences in health at the simplest level can be called inequalities. They're measurable differences in health status between different groups. Now, the difference between health inequalities and health inequities are some of those differences that we see between different groups in a population are what we would deem unfair or unjust. And those have been then deemed inequities. So as an example, there may be consistent differences, for example, between men and women. For example, the fact that women live longer than men, but that may be not necessarily deemed unfair if it's really perhaps more of a biological difference that's just across all of us as humans. But what becomes seen as an unfair or unjust difference could be the fact that, for example, wealthier people live longer and have less disability than people who are living in poverty, or that people based on their race or ethnicity have differences in health outcomes or differences in access to health services. So I hope that explains a bit about what the social determinants of health are and what we mean when we say health inequalities and health inequities. So just to move to another topic, what we're seeing right now is a health system that is still very much based on a focus on biomedical factors and not yet focused on looking upstream of these what we see in clinics and hospitals. What we mostly focus on right now and what we pay people to do is fairly biomedical in focus, prescribing certain medications, ordering tests, and also doing procedures that influence kind of people's physical makeup. What I think part of our work and what I see the future holding is what I've called upstream health systems, which would be systems that take into account the fact that social factors play a huge role in determining people's health and actually integrating within a biomedical approach a focus on these social and even economic factors. Now, I know this is hard to envision because we're all used to the system that we have right now, but let's imagine what an upstream health system could look like. And some of the work at the lab helps describe this, and there's more on our website about it. What this could look like is a system which routinely collects information about people's social status and these social factors, or derives it perhaps using more advanced artificial intelligence methods and linkage of people to things like information from the census, using things like postal code. But we develop this rich sense of, at the individual level, what is going on in terms of people's social determinants, and then integrate this into individual care plans, things that help people with social needs, so potentially new programs to help people around finances, employment, food security, housing security. And some of the work that we've done over the years has actually been to develop these types of interventions. But also it could help organizations like a family practice help think through where should they be putting their efforts, and within our roster of patients, where are the hotspots? Where's the kind of the people who need our help the most? And then finally, at more of a whole organization level, like at going from individual doctor practices to maybe the whole clinic or hospital, it could lead us to think about what should be changed in terms of the types of hours of operation, the business practices, but also things like where are we procuring services from, what are our employment policies, and what are the work conditions of people in the system as well. All of this could then flow up to bigger advocacy efforts to actually change the policies that shape these social factors. So that's a bit about what maybe an upstream system could look like. To think about primary healthcare, I think it's ideally situated to be really thinking upstream. We develop long-term relationships with our patients. We engage with them over the course of their life at every life stage, and we, by our nature, serve the whole population. So it's a really fantastic foundation to think about these types of upstream interventions. Again, I know we are far from this, and there's lots of questions about how this would be funded and how it would actually work, what sort of new workers and professionals would need to be part of these systems. But I actually think we're already on the road to this type of system. Some of the things that I see pointing us this way is a deeper interest of governments across Canada in thinking about population health and managing population health, and actually not just kind of seeing the system as needing more and more downstream intervention, but really moving upstream. So some three maybe kind of just to end, three kind of ideas for the future in terms of primary healthcare, which is really the focus of our care. One is actually envisioning the way that we pay primary care providers, such as family physicians, nurse practitioners, to actually adjust the way we pay, not just to move away from fee-for-service into a model that's more based on a roster of patients, but actually adjusting for complexity. This would have the effect of reducing people cherry picking certain patients and not taking on those who are more socially complex. But also, it would really reward providers to deliver good and high quality care to the people who need it the most. So I think funding that uses this type of information and adjust for complexity would be key. I think the second area is really building out primary care teams with people who can take on these social challenges that I've talked about and start to integrate this into the care that they provide. And also, think about it as enabling more proactive care, using the rich data we're starting to accumulate to engage in more proactive care. So not just depending on people coming in, but using it to reach out to patients and remind them and say, these are things you could engage with. The third kind of idea is something which I've learned from colleagues in Scotland and other countries, is starting to envision a network of primary care clinics in Canada that are all really deeply committed to tackling social determinants and reducing inequities. In Scotland, they have a network called GPs in the Deep End, and they mean, the general practices who are serving the most marginalized and the poorest communities. And what this has been is an amazing network to share ideas and challenges, but also to engage in joint advocacy and also sharing models of care within this network. I think this could be really powerful for Canada, and it's something which is actually something that Upstream Lab is hoping to help contribute to and help get started. So I hope that these ideas are useful to you, and certainly there's lots more about our work on our website. And it's been a real privilege to be involved with the Our Care work, and it's really exciting to see this conversation happening. Thank you for your involvement with this.